This chapter goes around the abnormalities of a pancreas. It is a very complex organ, so if I was you, this is why we give you the review chapters to go back and think, what is the function of a pancreas? You know, what does it do for the body? What happens when the body's abnormal? Any diagnostic testing? So that is why we give you those review chapters. It's chapter 43 for this one, okay? So it's easy to go back. You don't necessarily have to, but if you see that you're stuck with something, it's a very quick reference. These are the main enzymes that the pancreas create. They all have a specific function. You really need to understand what each one does to understand what the pancreas does. So obviously insulin we need to know, glucagon. We really need to pay attention to amylase and trypsin and lipase. I would really focus in that area to understand what those enzymes do. The importance of the function in the body, and what happens if they're not abnormal. So that's an area of focus there for you. All right, so just really quick, here's your basic picture. There is where your pancreas lies. Okay, right here. This is considered the head of the pancreas, just so you understand. Majority of the cancers that are found start at the head of the pancreas. Pancreatic cancer usually does not rear its ugly head until it has metastasized, but just so you understand, because it has many symptoms that are common to just GI disorders, basic GI disorders. So here's a quick picture for you to be looking at. Okay, so itis, what does that mean? It's an infection, right? So we have acute versus chronic. So acute means what? Onset. Chronic means it's continual. Okay, so acute, pancreatic duct becomes obstructed, enzymes back up, causing autodigestion and inflammation of the pancreas. You're going to need to know causes here. Please, 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 remember I told you the tables have a lot of our nursing process in them. Please refer to them. And chronic, this means if it's still the same disorder for the next 6 months, it is now considered chronic. Some of the main causes is diet, alcohol, smoking. Smoking and alcohol are huge, huge factors when it comes to GI disorders. So you're going to see smoking and alcohol are big. Chronic, progressively inflammatory with destruction of the pancreas cells replaced with fibrous tissues, pressure within the pancreas, increased obstructing of pancreatic common bile ducts. So if the pancreas, one of the biggest issues here is to the alert system of when we eat something, right? To give out certain enzymes to break it down, what we need, what we don't need. One of the biggest things we probably need to do with this patient is what? NPO. NPO is huge so that pancreas can rest. All right? So one of the biggest, these are the priority problems with somebody with acute pancreatitis. These are the biggest ones you're going to see. So let's go over them. Acute pain. It is one of the most painful things somebody can go through. All right? So we need to what? Care for that pain. We're not going to question their pain. It is very, very painful. All right? It is hard to even move. All right? Ineffective breathing pattern. Consider the area of where it is. Shortness of breath. Okay? Oh my goodness. Shortness of breath. Ineffective breathing pattern. Remember, it's kind of what? Lower, correct? You probably have somewhat epigastric pain a little bit there. Imbalanced nutrition. We're going to probably have them NPO for a very long time. It could take days. Impaired skin integrity. Not necessarily moving around too much. All right? All right. Collaborative problems and potential complications. So fluid and electrolyte disturbance. This is where, as you're studying, pause with each one of these. Start thinking to yourself and write these things down. What kind of fluid and electrolyte disbalance would I be seeing? Okay, if we can't get this inflammation, infection, whatever the cause is done, we're going to see some necrosis of the pancreas. So what kind of labs would we be looking at? All right, how often are we going to be monitoring? If this is due from an infection, should we start antibiotics? You know, continuous NPO. If we're NPO for longer than what? Probably 5 days was that golden hour I kind of said to you in my last lecture. What are we going to think about? Maybe an alternative form of nutrition. Bypassing that area, okay? This complication can lead to a systemic problem called shock, which could then lead to MODS, which is multi-organ dysfunction syndrome. The diagnosis is very simple of MODS. 2 or more organs are considered failing and you are in MODS. This is hard to reverse. Once you hit sepsis, once you hit shock, once you hit MODS, or DIC, it is hard to reverse the issue and the survival rate decreases immensely. Or DIC. We get into DIC a little bit more when we get into shock. Understand DIC is a shock of the body, right? What does the body do if we are losing volume? Okay, it wants to hold it all in. And this is the same for the clotting factors, okay? So we kind of clot off. We don't want to lose any more. But this can cause that other function of we could form multiple clots. Or we need to get rid of them. They're life-threatening. So we will start to what? Release all of it and we can start bleeding out. That is a very, very simplistic way of explaining that. All right. So tumors. Usually sometimes it could be cysts caused by the infection possibly, a little pocket of infection. Pancreatic cancer, again, some of the biggest risk factors was what? Smoking, poor diet, diabetes, and alcohol, long-term use of alcohol. Sites of lesion, again, are usually at the form of the head. Treatment most likely is probably palliative. Usually the longest a patient can survive or will survive, and again, these are just broad numbers, because it's caught so late, is usually with extensive treatment is about 2 years. So palliative care is huge. Chemotherapy, radiation, and surgery. Not every patient is a candidate for the surgery. It's called a Whipple, and I'll show you right here. Okay, so the Whipple procedure. So here we are. Here's your normal anatomy again. Okay, so the Whipple procedure is basically, it's like a rearranging, roto-rootering your digestive function here. So it decreases how big your stomach is. It removes all the portion of the pancreas that they think they've got all the cancer. They route it where? Into the, basically, this is where your small intestine went. You see where your jejunum is? So here's your duodenum. The jejunum is lower down. So basically here is, they cut here, they pull it up and bring it here and put it towards the pancreas. This buys the patient some time, hopefully, because it releases some of the work from the pancreas. All right. The multi-sump procedure, it's very extensive. Sorry about that, I don't know why that keeps popping up. It is a very extensive procedure. You are, what I would like for you to understand with this picture is it is very, very long and hard recovery. We have multiple drains and tubes to reduce inflammation and gather anything that could possibly cause an infection. We're giving nutrition through tubing. We are constantly irrigating the area. We have an incision for a risk of infection. You know, GI motility, is it going to come back? How long is it going to come back? Active motility, so we're possibly worried about circulation. Somebody with cancer is already very weak, worn, immunocompromised, so this surgery can be very life-threatening and it's very hard to recover. So understand those factors when you're studying. And that is what concludes the slides. Please, please, please pay attention to your role, your function, your intervention with those priority problems on the slides.